Hi everyone, welcome to this webinar on trauma care approaches. Today we'll be looking at what it's like for individuals who are living with trauma symptoms and post-traumatic stress disorder, as this can be incredibly difficult. In this presentation, you can expect to learn about a variety of evidence-based strategies and theories that can help you recognize and reduce symptoms as they relate to trauma. Learn about the current recommended evidence-based approaches, as well as what makes a clinician or organization trauma-informed. Before we jump in, I just want to let everyone know that this presentation is being recorded and it will be posted on YouTube within the next week if you wish to review it. And I have also allocated a time at the end of my presentation for comments and questions. But if there's something urgent you need to mention during the presentation, then please feel free to speak up or raise your hand. I'll give you a little background about myself. In my work so far, I've worked closely with populations who have experienced trauma. I've spent 5 years working with individuals who've experienced a traumatic brain injury. Naturally, a lot of times this is the result of an accident or an event, usually life-threatening, which can result in lasting trauma symptoms. Additionally, I've worked with various vulnerable populations who have been impacted by trauma as it relates to their family dynamics, ongoing neglect or abuse, family losses, substance use issues, poverty, systematic racism, discrimination, and oppression. Currently, I'm practicing as a qualifying registered psychotherapist at Clear Mind Therapy, and I can offer trauma-informed care to clients in our individual counseling sessions. So for the agenda today, we're going to be looking over the definition of trauma. We're going to be looking at the symptoms and reactions to traumatic events. We're going to look at the current or some of the current evidence-based approaches, and then we're going to look at what a trauma-informed or trauma-specific model might look like on an individual or an organizational level. So what is trauma? Trauma can be defined as the result of an event that causes physical or emotionally harmful reactions, which leads to adverse effects on the individual's functioning in a variety of areas in their lives, which can be lasting and prolonged. Trauma is defined as pervasive, meaning it is an unwelcome physical or emotional reaction or influence which can spread throughout various aspects of the individual's life. It's the result of an exposure to an incident or series of events which are emotionally disturbing or pose a threat to the individual's life. It impacts multiple areas of the individual's life, like I've said, which leads to adverse effects impacting their general functioning. Some examples of trauma or a traumatic event can include physical, sexual, and emotional abuse, childhood neglect, living with family members who have mental health or substance use disorders, sudden unexplained separation from a loved one, poverty, racism, discrimination, oppression, violence in the community, war, or terrorism. So the different types of reactions to trauma can typically fall under 5 categories: emotional, physical, cognitive, behavioral, and existential. I thought I'd provide a little anecdote about my experience working in trauma and how I've seen one traumatic event significantly impact an individual's life in all of these areas. So I used to work in the community as a rehabilitation therapist for people who had experienced typically a car accident or a brain injury. So they needed support or case management services to help them stay on top of their healthcare appointments, do their groceries, stay on top of their medication management. And I would go out in the community and I would meet with individuals, and we were typically paid for by the insurance companies. We had a case with an individual, actually 2 individuals. They were twins. They were sisters, and one of the sisters had been hit by a car. She survived, and she ended up being a service user at the company. Her twin sister actually observed the accident and observed her sister getting hit by the car. And that sister also ended up getting insurance coverage to use our services as well. So her just witnessing the traumatic event of her sister being hit by the car actually warranted insurance coverage and increased support from our company. So I had to help her. There's a lot of sort of processing trauma and dealing with her trauma. There's a lot of fear, and she had actually slipped into some substance use behaviors. And she wasn't able to live anymore with her family. Her family was very supportive, and they had so many resources available to her, but she really was not handling this traumatic event well and really needed our services for quite a while. So yeah, that's just an example of how a traumatic event, even if you're not necessarily directly associated with it, how it can impact your emotional, physical, cognitive, behavioral, and existential aspects of your life. She was unable to get a job. She was unable to secure housing on her own. She ended up having to go into rehab. So it really had lasting impacts on a variety of areas of her life and her general functioning. So next we have, typically traumatic symptoms can be divided into two sort of categories, immediate or delayed. So an example of immediate emotional reactions would be numbness and detachment, anxiety or severe fear, guilt, including survivor guilt, exhilaration as a result of surviving, anger, sadness, helplessness, feeling unreal or depersonalization, so feeling as though you're watching yourself exist almost in the third person, disorientation, feeling out of control, denial, constriction of feelings, and feeling overwhelmed. Some of the immediate physical reactions can look like nausea or gastrointestinal issues, sweating, shivering, faintness, muscle tremors, uncontrollable shaking, elevated heartbeat, respiration and elevated blood pressure, extreme fatigue or exhaustion, greater startle responses, so being more likely to be scared or startled, and depersonalization. Again, this is kind of related to not feeling like you're in your own body. Some immediate cognitive reactions would include difficulty concentrating, ruminating about the specific event, or racing thoughts, so replaying the traumatic event over and over again in your head. Distortion of time and space. So this would mean, for example, the traumatic event may be perceived as if it was happening in slow motion, or a few seconds can be perceived as minutes. So perhaps an individual was in a car accident. That car accident happens over the span of a split second, can happen so quickly, but maybe for them they perceived it as like a slow motion event. Memory problems, so not being able to recall important aspects of the traumatic event, and strong identification with other victims associated with the event. Some of the immediate behavioral reactions are startled reactions, restlessness, sleep, appetite disturbances, difficulty expressing yourself, argumentative behaviors, increased use of alcohol, drugs, and tobacco, withdrawal, apathy, and avoidant behaviors. And finally, we have the immediate existential reactions. So this would look like an intense use of prayer, out of the ordinary than what may be expected of the individual. Restoration of faith in the goodness of others, so really being open to receiving help and charitable work from others. Loss of self-efficacy, despair about humanity, particularly if the event was intentional, and immediate disruption of life assumptions. So the individual may have a skewed understanding of what it means to live a life that's fair, that's safe. Their beliefs about the goodness of others may change, or the predictability of life as well. Next, we have the delayed reactions. So the delayed emotional reactions would look like irritability or hostility, depression, mood swings, anxiety, instability. With anxiety, this could look like development of new phobias or increased generalized anxiety, or the onset of generalized anxiety. Fear of trauma reoccurrence, grief reactions, shame, feelings of fragility and vulnerability, emotional detachment from anything that requires emotional reactions. And then we have delayed physical reactions. So this can be sleep disturbances, nightmares, somatization. So this is an increased focus on or worried about your physical body. So increased awareness of body aches and pains. We can look at, there can be appetite or digestive changes, lowered resistance to colds and infection, persistent fatigue, elevated cortisol levels, hyperarousal, and some more longer-term health effects, which can include heart, liver, autoimmune, chronic obstructive pulmonary disease, to name a few. Then we have the delayed cognitive reactions. These can look like intrusive memories or flashbacks, reactivation of previous traumatic events, self-blame, preoccupation with the event, difficulty making decisions, magical thinking, which can look like believing that certain behaviors, including an avoidant behavior, will protect the individual against all future trauma. Belief that feelings or memories are dangerous. Generalization of triggers. So, for example, a person who experiences a home invasion during the daytime may now avoid being alone during the day. And then we have delayed behavioral reactions. So these can look like avoidance of event reminders, social relationship disturbances, decreased activity level, engagement in high-risk behaviors or impulsivity, increased use of alcohol and drugs, and withdrawal. And finally, we have the delayed existential reactions. So this can look like increased questioning, like why me? Why did this happen to me? Increased cynicism or disillusionment about others or the world around you. Increased self-confidence. So this could look like if I survive this, well, then I can survive anything. Loss of purpose, renewed faith, hopelessness, reestablishing priorities, redefining the meaning or importance of life, and reworking life's assumptions to accommodate the trauma. For example, if you were attacked, this would look like taking a self-defense class to reestablish your sense of safety. Next, we have some of the common evidence-based approaches that are used today. So the first one would be cognitive behavior therapy. It's one of the leading approaches in therapy today, and it can be easily applied to individuals who've experienced trauma. The emotional processing theory, which falls under the cognitive behavior therapy umbrella, suggests that individuals who have undergone a traumatic event are likely to develop associations to the event, meaning they will catastrophize objectively safe reminders such as the news, stories, and people and responses like numbness and fear. They will feel as though their entire world is unsafe or at risk. This theory aims at changing the associations that are irrational and unrealistic, as these can lead to unhealthy general functioning. The social cognitive theory suggests that the individual responds to trauma by trying to blend it into their existing cognitions and beliefs about themselves, others, or the environment. This leads to distorted perceptions about their own experiences, as well as perceptions about the world around them. An example of this is the following quote: "Bad things happen to bad people," meaning someone who is assaulted is in fact a bad person, which we all know is not true. So the social cognitive theory would look at reframing these cognitions to help the client redefine and regain the beliefs that they had prior to traumatization. Exposure tasks are employed in a controlled and safe environment. These are typically guided by the practitioner and can also be helpful for individuals who are avoiding situations related to their trauma. Gradually allowing exposure can build the individual's confidence and reduce the individual's anxiety over time. This also allows the individual to gain a sense of control and predictability, which will reduce escape or avoidance behaviors. Next, we have the eye movement desensitization and reprocessing approach, or EMDR. EMDR can be broken down into three main concentrations: past memories, present disturbances, and future actions. And it has 8 phases that can be worked on either in sequence or when the therapist and client believe it is appropriate to move on to the next sort of phase. So the phases are the history and treatment plan, preparation, assessment and reprocessing, desensitization, body scan, closure, and reevaluation. What EMDR aims to do is essentially takes the traumatic memory as it's been stored somewhere in your brain, it tries to take it out, reflect on it, work through it in a therapeutic and safe environment, and then desensitize the individual to that traumatic memory so they don't have the same physical, emotional, or behavioral sensations when they think about that traumatic event. It essentially makes the trauma symptoms milder over time with physical sort of actions while the client is working through the event. There is a video that is associated with EMDR that I want to share. It will be provided in a separate link. Okay. In therapy, counselors will often need to get further insight and context into the traumatic event to be able to select the most appropriate interventions and approaches. This means we'll be needing to ask the client questions about the specific event, which causes them emotional distress. Instead of asking why did or didn't the client do something during the traumatic event, it's best to reframe this question to be more trauma-informed by asking something along the lines of, "Are you able to tell me about what happened when?" The reason for this is because some of the why questioning can be perceived as the clinician faulting the client because of an action they did or didn't do during the event. And if you're trying to understand the client's thought processes during the event, it's best for the clinician to be specific, such as when he turned the lights off, how did that make you feel? When you're trying to get more specific information about the intricacies surrounding the event, instead of asking how long was the event or start at the beginning and tell me everything, reframing this would instead have the clinician ask the client, where would you like to start? Or what are you able to tell me about what was happening during the event? Current trauma research has indicated that the clients who've experienced trauma may have issues with storage of these traumatic memories. Therefore, reframing the question reduces the pressure on the client to recall specific timelines and details of the events, and instead it provides them the opportunity to recall or explain the event as they remember it and how it impacted them. Instead of, did anyone see this happen? You would want to reframe this to, can you tell me about any witnesses who may have seen you during this event? The reason you would reframe these questions is because the initial question could be perceived by the client as the clinician believing the incident occurred because of a lack of witness. As therapists, so much of our client discovery and exploration is through the proper use of questioning. In my supervisions and in my practicum so far, we've spoken a lot about proper use of questioning skills with clients. I've shared candidly that early into practicing therapy with some of my clients, I've admittedly been second-guessing some of my questioning skills, feeling as though if I keep asking the client for details, they may think I'm overstepping. When the reality is, most clients really just want to be seen and heard. In collaboration with my supervisor and a few other peers, it was advised to us as therapists that we should be doing frequent self-check-ins with ourselves and ask, is the question I'm asking for me or for the client? Meaning, will the answer to this question provide more insight into the client's needs and the direction the therapy session should go, or am I just asking out of my own curiosities? Which I think is an important rule of thumb to consider when discussing traumatic events with our clients. The three-pillar framework was designed to capture specific characteristics necessary to promote healing and growth for an individual who has experienced trauma. The safety column refers to a practitioner or an organization focusing on creating an environment for the individual so they feel at ease and relaxed, and it enhances their ability to continue development and completing activities of daily living. Connections refers to the interpersonal connections an individual develops with their peers, family members, and community supports to enhance their healing after a traumatic event. Managing refers to developing coping skills which will have positive impacts to proactively tackle life's challenges, as well as it addresses some of the lasting adverse emotional reactions or impulses that cause traumatic stress. Next, we're going to be looking at the difference between trauma-informed and trauma-specific interventions. Trauma-informed practices have the ability to go beyond an individual's healing needs and can offer trauma approaches to a wider audience and can provide broad-range targeted trauma approaches to entire organizations, school boards, cities, and specific populations. Also, trauma-informed practices include prevention services at a more universal audience. This could look like universities implementing specific safety measures throughout their campus. For example, at York University, there are multiple emergency poles scattered throughout the campus with an emergency call bell on each checkpoint. This would be an example of a trauma-informed practice. Trauma-specific approaches are tailored to specific traumatic events or are designed for specific individuals and provides interventions in response to trauma which has already occurred. An example of this would be a therapist who is trained and experienced in providing therapeutic interventions tailored to individuals who have PTSD as a result of time served during the war. Clinical practices can incorporate some key ingredients to ensure that they are offering trauma-informed services to their clients. These include involving their clients in the treatment process so the clients can be actively engaged in the decision-making process and the therapeutic planning. This component also encourages feedback from the client to the practitioner to ensure that the care plan is steering in the right direction with the needs of the client at the forefront. Secondly, an important clinical strategy incorporates appropriate trauma screening early into the therapeutic relationship, as this allows the clinician to have a better understanding of the client's history, as well as it can be utilized to better plan future interventions. This type of screening or assessment also can reduce biases if the clinician ensures to incorporate this practice into all therapeutic relationships. Similarly to the organizational level of trauma-informed practices, it is recommended that clinicians also ensure their staff are adequately trained on the up-to-date recommended evidence-based approaches. Lastly, a clinician or clinical practice should be promoting collaboration with other healthcare practitioners. Due to the complexity of trauma, clients will often have multiple behavioral, social, and physiological healthcare needs. A clinician should be able to determine whether or not they are best suited for the client, or if the client's care needs need to be supplemented with a referral to another practitioner who also follows a trauma-informed approach. I'm going to end this slide off with a quote from a doctor at the University of California. It is very difficult for most providers and clinics to help patients heal from a lifelong trauma and prevent re-victimization on their own. Forming partnerships with community-based organizations is essential. And this leads us into our next slide, which is how organizations can incorporate a trauma-informed approach. Organization practices that aim to fit into a trauma-informed care model can be broken down into a few ingredients as well. These include leading and communicating about the transformative process to transform into a trauma-informed facility, meaning designing plans, policies, and procedures that empower multiple components and areas within the organization to involve them in the change process. So there is a universal understanding of the purpose of the changes and why the organization wants to transform into a trauma-informed facility. Engaging the patients in the planning is the next key ingredient, as this population can provide powerful insights and first-hand perspectives due to their own personal experiences with trauma. Additionally, it is recommended that if an organization does incorporate clients into their trauma-informed planning, that they should be compensated in some capacity. Training the staff, both clinical and non-clinical, ensures that all staff who belong to the organization are creating trusting and non-threatening environments for their clients, as well as foster feelings of safety and acceptance throughout the organization, including any staff ranging from desk administrative workers to psychologists and security guards. Creating a safe environment ensures that the client feel physically, socially, and emotionally safe while they're in the organization's facilities. And this ensures reducing the likelihood of re-traumatization. Physical environment modifications, which incorporate trauma-informed approaches, can look like increased lighting in common areas, parking lots, reduced loitering, increased security staffing, monitoring and limiting noise levels, and adequate signage notifying patrons where all the exits are. Socio-emotional environmental changes would mean the organization ensures staff are trained on appropriate interpersonal boundaries as well as conflict management. Prevention strategies that an organization can adopt would include offering information sessions or trainings aimed at raising awareness of traumatic stress, allowing staff to explore their own traumatic histories, incorporate clinical supervision with providers to meet with staff regarding their client interactions, encouraging wellness activities, and allowing staff to take time off for mental health. Employing a trauma-informed workforce ensures that staff are suited and hired for trauma-informed work. By examining their past experiences with specific and relevant populations, settings, and their own personality or approaches. A longtime friend and prior colleague of mine works at the Durham Region Police Department in the Victim Services Unit. This is a great example of a trauma-informed workplace and organization. The police department itself is not necessarily trauma-informed, but the Victim Services Unit, which operates out of the police station, abides by its own trauma-informed policies and procedures. My friend works as a caseworker on the domestic violence team, where she is called out into the community to offer case management services as well as trauma counseling to the victims of abuse and violence. So what does it mean to be trauma-informed? This can be broken down into three sort of steps. So for approaches, this refers to how a practice will adopt one of two approaches, which is either treatment and healing or prevention and promotion. The treatment and healing approach is aimed at reducing symptoms or signs of the individual's distress following the traumatic incident, whereas the prevention and promotion approach is targeted towards reducing the likelihood of the trauma event occurring at all in the first place. The socio-ecological model refers to specific efforts that are targeted at promoting positive change in an individual's beliefs, behaviors, and personal attitudes. This model is also aimed at promoting positive changes in the individual's relational aspect of their life, so their families, romantic partners, and peers. The socio-ecological model also is targeted at promoting trauma-informed approaches in the organizational or community systems or domains, including schools, workplaces, neighborhoods, child welfare centers, educational systems, towns, and cities. The target model is in reference to what exact domains the intervention, policy, or process is designed for, whether it be trauma-specific services for the individual group or groups who've experienced similar traumas, or more broadly, which can be applied to larger settings like organizations and populations. We are nearing the end of my presentation. I did want to share two important resources. The link at the top provides resources including community groups, service providers, educational content, podcasts, apps, videos, and more about what it means to be trauma-informed. And the second link is a selection of outpatient services offered through Ontario Shores that individuals can access however they wish. Thank you all for listening to my presentation. Now, there was time left for a discussion period, and I have some questions left by the group who participated in this webinar. Before I begin, I wanted to start off and ask a question. Are there any techniques or interventions which I have not mentioned today that you have tried? What was the success with them, and why would you recommend those over others? Some of the questions asked by the participants in the webinar were, is there anything that you would recommend that a friend or family member could do to help someone dealing with a trauma response, whether it's trauma-informed or trauma-specific or just general advice? My response to this would be, if you have someone in your life, a family member or loved one who has experienced a traumatic event, I would, if you have the capacity to, maintain a safe space with them, allow them to continue to talk to you through it, keep that door open. If you feel that their trauma reactions are beginning to be concerning or you don't have the capacity anymore to support them, I would steer them in the direction of trauma-informed services and trauma-informed resources, potentially lightly encourage them to try and book a session with a therapist who can help them work through their trauma, but really maintaining that open door if you are able to, if you have the capacity, so that they can continue talking about it. The more that they kind of retreat and not talk about it, the bigger the issue could be in the long run. Another question we got during the webinar was, if you know someone who has experienced or is experiencing a trauma response and doesn't appear to be handling it well, but also doesn't seem to want professional help, is there anything you would recommend doing to try and help them? So similarly to the last answer, is I would maintain a safe space with them. If you, as the friend or loved one, can continue to offer them a safe space for them to share with you, talk about the event, talk through their kind of emotional processes, that's great. I would also encourage them to continue to engage in activities where they can kind of express themselves, either creatively through poetry, artwork, music, or also do some reflective activities like meditation, journaling, self-reflection, yoga, maybe engaging in a new hobby. If they maintain their involvement in sort of areas of their life that have typically brought them joy, these areas can really boost their self-esteem and help them cope through this sort of dark period after a traumatic event. Another question we received in the group was, is there a time frame that is best to treat trauma? I would say as soon as it occurs, the better, the less likely to have sort of delayed reactions to the traumatic event. As soon as that individual is ready to talk about it, they will start to see results as soon as they're ready, essentially. So the sooner the better. If you know someone's gone through a traumatic event and they aren't really talking about it, again, maintaining that space for them if you're comfortable for them to talk with you, or continuing to encourage that, they speak to a professional about it. So that is everything for my webinar today. Thank you so much for listening. Have a great day.